Our next speaker is Dr. Roger Mcintyre, who is a frequent presenter here at the Psychiatric Symposium. He is internationally known, a lecturer from Toronto, Canada, where he is professor of psychiatry and pharmacology at the University of Toronto.
And thank you very much for introducing me. I just want to make sure, just a green light, everyone can hear me okay? Just a green light to say you're hearing me okay? Yes, beautiful. Okay, sounds like I saw a yes come through. People can hear me. That's wonderful. Thank you so much. And thanks, Ben, and congratulations on putting this meeting together. I know firsthand for putting together meetings, it's a lot of work goes on behind the scenes. And Ben, you and your team are to be thanked and congratulated. We as healthcare providers have a tremendous privilege of meeting patients and families who are affected by mental illness. And we want to keep up to date on information that is not just interesting, but also relevant to what we do with our patients. And it's these types of conferences that allow knowledge exchange and knowledge transfer so that we're kept up to date. We do our best with the best material we have. So thanks for that. And thanks for inviting me to be part of this. And I'm actually quite thrilled to be re-invited back. So thank you. We're going to get right down to business. This is a topic that I really thoroughly enjoy speaking to. It's a topic that I have spent all of my career, frankly, researching and trying to understand, trying to unravel this intersection, the underlying neurobiology and psychosocial and a variety of factors that are subserving this intersection of medical comorbidity and mood disorders. And if I was to be quite candid and to be very brief, I guess there's really two reasons. There's more than two, but there's two reasons why this topic is so relevant. First is all of us know that when we see people who have depression or bipolar disorder, with one or two exceptions, just about everybody has another concurrent disorder or so-called comorbidity. And we know that people who have depression and bipolar disorder are affected by a long list of medical problems at a rate considerably higher than would have been expected by chance. And the implications are obvious because these additional problems contribute further morbidity and actually mortality, specifically cardiovascular disease being the most common cause of premature mortality in people with depression and bipolar disorder. So there's a very clinically oriented, very pragmatic reason why this topic is so critical for all of us. There's another reason why this topic really took my interest and why I've engaged in this research is that in 2021, we are still attempting to unravel the underlying pathogenesis or the pathoetiology of mood disorders. And one strategic approach to try to answer this question, what causes mood disorders, is to better understand what's causing some of those comorbid conditions. Because if these comorbid conditions are affecting people with depression and bipolar disorder at a rate much higher than would be expected by chance, that gives us a reason to believe there might be a shared pathogenesis. So this may shed some light on the underlying pathoetiology or genesis of depression or bipolar disorder, and may also inform next treatments that we have for patients. And so this isn't just an academic enterprise, it's an enterprise that is really, in fact, trying to ultimately know what's causing depression and maybe one day develop a treatment that's more disease modifying for our patients rather than simply being symptom suppressing, which unfortunately has been the case for far too long. I want to start off, if I can, with getting into some of the factors that are operative here. And already we've moved into childhood maltreatment, CM. So why am I starting on childhood maltreatment? So, I thought we're talking about medical comorbidity. Well, we are. And what we're trying to figure out is what is the underlying cause of medical comorbidity in people with depression. And we know there's not one singular cause. What we do know is that childhood maltreatment which has been variably defined, variably operationalized, but I'm referring to abuse, physical, sexual abuse, neglect, emotional, physical neglect, psychological neglect. Of course, there's different types of abuse, including verbal, emotional. These events are the most powerful, modifiable risk factor for depression. There's a concept in population-based epidemiology. It's called population attributable risk, PAR. Population attributable risk refers to what degree an event accounts for the overall risk of the condition in question. So in other words, for people with depression, it has been established that 50% of the risk of depression can be attributed to childhood maltreatment. That's incredible. And what this slide is saying is that if you have been a victim of trauma under the age of 7, of which more than half of our patients with depression report, there's an attenuated response to antidepressants. And we'll come back to this a bit later. But what I wanted to, in fact, begin the conversation with is what's going on here. And the way I want people to think about patients who have depression with medical comorbidity, depression without medical comorbidity, these seem to be different types of depression. And people who have trauma and depression are more likely to have obesity, diabetes, heart disease. Now, do you need to have a history of trauma if you're a person who's depressed to have an elevated risk of these cardiometabolic problems? No, you don't, but it's just more common in that group. So when we think about medical problems in our patients who have depression, we think about the usual suspects, unhealthy behaviors like smoking cigarettes. We think about our patients being so habitually inactive. I think many on the program today would be experts in more policy and public health, would say that our patients don't have sufficient access to healthcare resources. That contributes, and you're all right. And also, we know some of our medications can cause some of these problems or add to these problems like weight gain and so on. But I wanted to speak to this topic because we've reported that trauma not only is associated with an elevated risk of depression, but people who have trauma and depression are more likely to have obesity, diabetes, and heart disease. Another area I wanted to touch on that I don't think receives as much attention, although I think the last 2 years during COVID it did, that's the issue of loneliness. And I've been saying to a lot of people that we don't just have a COVID-19 pandemic, we have a loneliness pandemic all around the world. And this is affecting people right across the age span. Younger people more likely to report themselves as lonely. By the way, just a bit of a definition. Loneliness refers to subjective perception, subjective experience of a gap between what's desired interpersonally and what exists. That's different than social isolation, which is an objective measure. Keep in mind that not everyone who's socially isolated is lonely and vice versa, although they are correlated. So why are we talking about loneliness in a conversation about depression and medical comorbidity? Where are we going with this? Well, we did a review of this. Caroline Parks was part of my lab at the time. We found that if you're lonely, you're more likely to have depression, anxiety, obesity, cardiovascular disease, and more likely to have suicide. Now, that in itself is an interesting topic, and for those maybe less familiar, loneliness can be evaluated with a variety of standardized scales. Many might know the UCLA scale. There's a longer and a briefer version. The UCLA loneliness scale, its namesake telling you what it evaluates, and about 20 to 25% of people report loneliness. Just 2 weeks ago, the media picked up on a report published in JAMA where it was documented that if you're over the age of 60 or 65 and you're lonely, you're more likely to be prescribed antidepressants and anxiolytics and hypnotics. But I want to keep this focused on medical comorbidity. In other words, I not only think it's related to childhood trauma in some cases, but I also think in some cases it relates to some of these aspects of loneliness. Now, someone might be asking, well, how does loneliness lead to medical problems and depression? Well, A bit later on, I'm going to show you that loneliness activates the stress response system. It increases the release of cortisol, increases inflammatory markers, and we know that these two effectors alone could increase the likelihood of obesity and diabetes. In other words, there's a variety of interpersonal and modifiable interpersonal factors that are critical to medical morbidity in our patients. This was a review of studies of COVID-19 on depression. What my team member Jackie Young did is she summarized the worldwide literature looking at depression and anxiety and related conditions during COVID. Nobody's unaware that we have seen a massive increase in depression and anxiety around the world. And what's interesting is that what we've noticed is that younger people under the age of 30 to 35, women, and people who are unemployed tend to be the ones more often reporting depression and anxiety. Why I bring that up is that when you look at women and men separately, there is in fact now lines of evidence that would suggest, maybe even indicate, that women, when compared to their male counterparts, are more likely to have medical problems if they have depression. That's interesting to me because I also know women are more likely to report trauma and more likely to report elevated measures of loneliness in some of these surveys. You may have also heard that just about 6 weeks ago in Lancet, this report appeared where it was documented that around the world during COVID-19, there's now been the origination of almost 120 million new cases of depression and anxiety. So we know that depression and anxiety are the most common disorders around the world. And since the start of this awful pandemic, we've seen an increase in depression and anxiety, 120 million cases estimated. What's also interesting to me is we're also seeing a rise of other types of chronic problems like depression, like obesity, and like diabetes mellitus. Let me, in fact, if I can, just show you this slide, because I think this is really, really interesting. In other words, I'm making the case that I do believe that the underlying causes of depression are overlapping with some of the underlying causes of these medical comorbid conditions. This could be a side effect of a medication, it could be the individual patient behavior, but it also rests in a variety of other social factors. This is, I think, a timely study that appeared given what's happening with COVID, insofar as this was a study looking at cytomegalovirus. Now, everybody knows cytomegalovirus. It's a well-known virus. It may be less well known that it typically sits quiet in your body. Where does it live? It typically lives in your brain. It lives in your dentate gyrus, which is a pre-processing center for your hippocampus. This was a study where they documented that adults who have serious mental illness are more likely to have a smaller dentate gyrus, and those with the smaller dentate gyrus, notably the guys in this study, girls in other studies, have a higher likelihood of having infection to cytomegalovirus. And the idea here is that cytomegalovirus is causing this brain volumetric change. Now, I bring this up for another reason, and that is that we now know that there is, in fact, a long-standing history where medical problems can cause mental illness. In fact, the great example in the history books of psychiatry was what was referred to as general paresis of the insane, otherwise known as syphilis in your brain. So it's not just that depression and medical problems have overlapping pathoetiologic factors, it's also the case that one can cause the other. And this is an example, I think it's timely, where infectious diseases can set in motion molecular events, a cascade of events that puts the person at risk of mental illness. And no doubt you heard this story, that if in fact you've been infected by COVID-19, about a third of people after they have been infected with COVID now have a neurologic or psychiatric problem. Is that because the virus is going into their brain and causing disruption? Maybe. I don't think that's the whole story. Maybe it's the cytokine storm. Maybe it's the inflammatory activation in response to the actual virus that's leading to this. Again, there's other factors at play in terms of psychosocial. This is obviously very traumatizing. But let me not forget to leave one other aspect with you. We just published this paper about 3 months ago, Felicia Saban, another member of my team. And what we did was we discovered if you have depression or bipolar disorder, you are at much greater risk of being infected by COVID, being in hospital because of COVID, and dying because of COVID. We all know that people who have pre-existing chronic diseases like obesity, type 2 diabetes, heart disease, kidney disease, cancer, the list is long, they are at greater risk of COVID and its complications. In our analysis, we added to that list depression and bipolar. And just 5 weeks ago, the CDC in Atlanta added mood disorders and schizophrenia to the list of at risk of COVID and its complications. By the way, some might be wondering, in this analysis, did we adjust for the confound of obesity and diabetes and smoking and so on? Yes, we did. And the risk still persisted. And this speaks to something about our patients. Now, there's social determinants at play here. There always is. But at the very biologic level, there is dysregulation of the immune system in people who have depression. It is intrinsic to the illness. And that intrinsic alteration in the immune system may account for why we see such relatively high rates of hypothyroidism in people with depression or bipolar disorder. Have you ever wondered why we see such high rates of migraine or ulcerative colitis, Crohn's disease, other types of vasculitides and rheumatidities, as well as a variety of immune problems like dermatitis and psoriasis and so on? Because we do think this is intrinsic to the actual illness state. A moment ago, I talked about loneliness and its association, not just with depression, but medical comorbidity. And it's a modifiable event. In fact, there was a report about 6 months ago that a very low-tech, high scale, and very low-cost intervention is capable of reducing loneliness in people. It was a wonderful study that was done. This is not a very difficult phenomenon to mitigate. Linus Wilkalis is part of my lab, and we were looking at what effect loneliness has on a variety of stress response systems. And now when we think about stress response systems, we typically think about the hypothalamic pituitary adrenal axis. That's the cortisol system. And you know that's abnormal in people with depression and likely is accounting for why we see greater abdominal obesity, type 2 diabetes, and heart disease in our patients. Not the whole story, but part of the story. Other aspects of the stress response system to keep in mind is the catecholamine system. In other words, increase in adrenaline. This is the fight or flight response. And then thirdly is inflammation. So what happens when we're under states of chronic, unpredictable stress? Loneliness is a state of chronic, unpredictable stress. Also, COVID-19 has been a state of chronic, unpredictable stress. What happens is that the immune system reacts to that as though it's recognizing a foreign pathogen and begins to release cytokines, chemokines, cell adhesion molecules, chemoattractant proteins, a bunch of molecules that do a lot of damage to your body and result in accelerated aging, result in onset and development of chronic disease, including but not limited to obesity and diabetes. Remember earlier I said that childhood maltreatment accounts for about 50% of the risk for depression? That's been replicated. That's called the population attributable risk, the PAR. This was a study that came out of the UK, published in the American Journal earlier this year, where investigators used a large biobank in the UK to evaluate the causative effect of inflammatory markers on depression. A couple of takeaway points. First is everybody knows that inflammation can lead to a variety of medical problems. It can also lead to depression. Now, the overall contribution to the vulnerability is around 3 to 5% in this analysis. That's not 100%, that's not a 0%. So I would describe that as a modest piece. But keep in mind that when you look at the risk of depression, it's multifactorial. And so I would proffer the idea that the reason why you and I see so many people with so many medical problems and depression is because in many situations, the underlying pathogenesis is overlapping. Let me now, in fact, show you how these things can crosstalk. This is an analysis that was done in some poor kids in Chicago. This was published again this year in the American Journal. And the concept here is depression overlapping with medical comorbidity. And in these kids, you all know that about 20% of children in America are below the federal definition of poverty. So a very large percentage of children in America are living in poverty. And these kids were scanned. These were young children living in poverty. They had their brain scanned, and they provided a blood sample, a biospecimen. And what the investigators found was that these children's blood was inflamed. They had elevated inflammatory markers. When they looked at the brain scans, they identified something pretty interesting. In these kids, their amygdala was lit right up. This is the fight or flight center of the brain. And that was linked to inflammation. And what's interesting is on a separate analysis in the same study, the investigators found that the inflammation was also linked to altered function of their striatum. Now, the striatum is responsible for reward, like anhedonia. So this is interesting. Poor kids are more likely to be inflamed, and poor kids who are inflamed are more likely to have anhedonia, apathy, cognitive problems, and anxiety. That sounds a lot like depression and anxiety to me coming up. These kids are not yet depressed and anxious, but this sounds like it's a certainly fertile ground for that. So what I want people to think about is not only the overlap of depression with medical comorbidity, but more specifically, what the overlap is with. It's with cognitive problems, reward problems like anhedonia. We see people who are obese, diabetic, who have heart disease, they come to us and they say, I'm tired, I'm fatigued, I've got no motivation, I'm so apathetic. Well, that's because the underlying pathogenetic substrate is likely involving aspects of inflammation and insulin resistance. So the link between medical comorbidity and depression broadly is in fact a more narrow link with aspects of reward, aspects of cognition, and frankly, aspects of sleep. And just to remind you, in patients that we see with depression, 3/4, probably even more, have anhedonia. This is a complete and total underestimate that only 30% have low motivation, but certainly it's a lot of people. And depression itself is emotionally blunting, and in part, this could be medication related. So I've noticed when I see people with depression and medical comorbidity, they are more likely reporting anhedonia. They're more likely fatigued, apathetic, often say they have got chronic fatigue, not motivated, emotionally blunting. And we think this is in part linked to this inflammation. By the way, since we're on the call today to hear about this intersection and to hear more about where the neuroscience is, I also just wanted to let you know that the way we think about anhedonia in depression is how it's defined in DSM-5. It's the absence of pleasure, but it's a bit more complicated than that because we know that anhedonia has 3 separate dimensions. Anhedonia could refer to the absence of experiencing pleasure, which is probably how we all know it. This is when your TV show you like is not interesting to you. You're not really enjoying being with friends. You're not enjoying a lot of things in your life. That's what's called sort of consummatory anhedonia. But there's also anticipatory anhedonia. That is the lack of pleasure in anticipating a pleasurable event. Now, patients don't come to us and say, I'm here today because I have anticipatory anhedonia. They come to us and they say, I'm tired, I'm fatigued, I have no motivation. And that's usually code for anticipatory anhedonia. And thirdly, they have a problem with what we call reward learning. In other words, they don't learn as efficiently positive reinforcing events. They become very skilled at learning negative reinforcing events. That's called reward learning. And all three of these dimensions of anhedonia may be affected in people who have depression. Before I depart COVID and then really focus more on non-infectious overlap, you all have been hearing about what's called long haul, long COVID syndrome. And just recently, the World Health Organization has called this post-COVID conditions. There's a lot of monikers out there. We don't really know what this is. This is a very poorly defined phenomenon. There's over 200 symptoms now attributed to so-called post-COVID condition. Some of the most common are brain fog, terrible fatigue, and non-specific anxiety and depressive symptoms. Some have made the case this has some facsimile with chronic fatigue syndrome, some overlap. That's true, so-called myalgic encephalitis. I think we're really not clear what this is. But what we are clear is that it is debilitating for those who are affected. And we also are clear this probably involves some type of immune system brain communication that's going on that's leading to this phenomenon. And again, this incredible intersection of medical comorbidity along with depression. Now, for some reason, the legend here on my slide got a little bit taken up by the colors. I don't know what happened to my slide here, but that doesn't matter. I just wanted to make this point because I don't want to leave this COVID-19 situation without just finishing my thought here. I was so pleased to see that the CDC had added depression and bipolar and schizophrenia to their list of at-risk conditions. And in keeping with the thesis today, that's a reminder that our patients are at greater risk of medical problems. Now, I've been encouraging all my patients to get vaccinated and get the booster right away, and that's now the recommendation from the CDC. The related question, which is a different question, is will our patients with mood disorders or schizophrenia, will they require more frequent boosters than people in the general population? And I don't know the answer to that question. But the reason I'm raising it is, you know why? Because I'm making this point that we have immune dysregulation in our patients. But this was a study, again, I'm sorry for the way the slide turned out, but it doesn't matter, I'll speak to it, is that when you look at the immune response to people who have depression, who have received the flu vaccine or hepatitis C or measles, or in this case, varicella zoster, when you look at their immune response, whether antibodies or the cellular response, it doesn't seem to be as robust as people in the general population. Now, there's some fine print to this because the fine print also indicates their immune response is not as robust if they're not treated. But if they're treated with antidepressant medicine, which is what this study showed, the immune response is actually fully back to normal. That's kind of cool on so many levels because that does give indirect support for what's now well established that antidepressant medications could affect the immune system and that could affect risk of medical problems. And I've wondered for a long time whether treating patients who have depression and cardiovascular disease, which, by the way, when you treat depression in a patient with cardiovascular disease, there is a suggestion you could actually have a more favorable outcome for the cardiovascular disease. There's a suggestion of that. And what we've wondered is whether or not treating depression, among other things, alleviates some of the hyperinflammation that is seen in depressed patients. And that's just one idea. Let's say more about this. In depression, the cytokines that are most elevated are IL-6 and CRP. By the way, they tend to go together. I know people have probably not studied immunology for quite some time, but what happens is when your body's under a lot of stress, it releases interleukin-6. And interleukin-6 then talks to your liver, which produces the CRP. So they always kind of go together. And then TNF alpha is quite elevated. And about 20 to 40% of patients with depression have elevations of these markers, and especially if they have medical comorbidity. So in short, there's a number of factors that overlap why people with depression have more medical problems, and not just chronic non-communicable diseases, but also infectious diseases like COVID. And part of this, I didn't get into the details of this, it's got something to do with the genetics, and that's something you can never escape is your genetics. But there's modifiable factors, and they're listed here. I won't review them all. I've covered most of them or many of them. But the point is that there's many, many factors at play, but I want to use the word modifiability. And if there's any takeaway message, I think from this discussion on medical overlap with depression and bipolar disorder is prevention is always better than treatment. And in early phases of the illness, when the patients tend to have less of these medical problems, that's when the motivational therapy, the psychoeducation, the lifestyle modification, that's when it's most likely to be beneficial. But look, I've been a clinician for over 20 years. I've seen tens of thousands of patients and families, and I'm fully aware of the fact it's one thing to have aspirations for your patients. It's a different thing to put these things into action and to get that behavioral change, especially when they're lacking motivation to do a lot of these things. Now, let's, if we can, just have a look at this issue, and that's the role of anti-inflammatories. Remember I was saying that, we as clinicians are always looking for new strategies to treat patients. I started off to this program by saying this area of medical intersection with depression is relevant because it's so common in clinical practice. And maybe it might shed some light on some new ways to treat depression. Well, here's an example of the latter aspiration being partially addressed. So here's a meta-analysis looking at drugs that are anti-inflammatory. These are drugs like COX-2 inhibitors, NSAIDs, omega-3s, statins, minocycline. Minocycline, you probably are thinking, minocycline's an antibiotic, isn't it? It is, but it's also an anti-inflammatory. And taken together, what we're seeing is a signal of antidepressant effects. And for some of you on the call today who work on consultation liaison services or work in the medical population primarily, for example, in a hospital clinic, you would know that patients who take biologics, these are the monoclonal antibodies to treat, for example, Crohn's or ulcerative colitis, psoriatic arthritis, and so on. These patients, when they receive those biologics, very frequently report a significant improvement in quality of life, in vitality, in well-being. And that's not simply because the medical problem is being treated. And so we have now data sets that are hinting at antidepressant effects of anti-inflammatory drugs. Admittedly, there are limitations to these studies, as there always are. And the limitations include, but are not limited to, the fact that a lot of these studies are very small. There's a lot of differences across studies in terms of how they evaluate and measure outcomes. So the bottom line is I wouldn't say that if we were talking about clinical practice guidelines in depression or bipolar, the most up-to-date CPGs in America in depression and bipolar is the Florida Medicaid guidelines that were published last year, 2020. You can download those free at Florida Psychotherapeutic Medication Guidelines. In those guidelines for depression and bipolar disorder, which I was contributed to, working with a team down in Tampa, we did not put anti-inflammatory drugs on the list, not because we weren't aware of it, just because we didn't think it quite made the grade, so to speak, with respect to the quality of data. But this is an active area of work, and there's a related but different body of evidence indicating that statins actually, in fact, can treat depression. And what's so interesting is that you all know that if you have a cardiac event, let's say you had a myocardial infarction, and people with depression have extraordinary rates of major cardiac events, like myocardial infarction, which is the most common cause of premature death in both depression and bipolar disorder. Well, if you have an event like that and you exit the coronary care unit, you're going to be probably placed on a statin, among other things. You get that cocktail, And there's now been about a half a dozen studies that have shown that if in fact you have a cardiac event and you are put on a statin, which is the cocktail, among other things, you have a much lower risk of developing depression after a cardiac event. And just a reminder, I think everyone knows this, that depression not only leads to cardiovascular events at an extraordinary rate, but cardiovascular events lead to depression at an extraordinary rate. So if we had an exam today and the exam said, which of the following treatments has been shown to prevent depression? You're going to circle statins. It's been shown to prevent depression in people who have cardiovascular events. Now, there's no doubt about it that along with social, economic, healthcare determinants, along with aspects of insecurity of food and finance and housing, we also in fact have recognized that for many people, once you set in motion this cascade of depression and medical comorbidity, you really are setting in motion not just 2 or 3 or 4 disorders, but a much more complex biotype of depression. And what I mean by that is my experience is in accordance with the published literature that the more and more medical problems you have while you're depressed, the less likely antidepressants work. Now, my argument is not that we shouldn't use antidepressants. We absolutely should use antidepressants. I'm just saying that the likelihood of success drops off, and I think everybody knows that. And we don't know entirely why that is, but one of the reasons has got to do with, again, inflammation and insulin resistance. And you all know that in our patients, one of those modifiable factors is obesity. And one of the questions I'm often asked is, does the obesity and depression, is it the principal cause of inflammation? And the answer is no, it's not. It's a major cause, but not the only cause. And so it stands to reason this is something we should be avoiding to the extent we can, working with patients, of course, and try to avoid weight gain promoting psychotropic drugs. Now, I mentioned in passing about 5 minutes ago that if we treat patients with depression and cardiovascular disease with antidepressants, there is a suggestion that the use of antidepressants in someone with concurrent depression and cardiovascular disease may bode well for their cardiovascular disease. There's a separate line of research I haven't made reference to yet that if you have stroke and depression and you are prescribed an antidepressant for your depression because you had surrounding your stroke, that the outcomes, that is the functional and quality of life outcomes as the consequence of your stroke, are improved. So our treatments can have collateral halo effects. And here's an analysis I thought was really interesting. This is using mindfulness-based psychotherapy. So mindfulness-based psychotherapy has been proven effective as a treatment and prevention of major depressive disorder. Okay, makes sense. It's also been shown to be effective for other types of chronic diseases as well. And in this analysis, what investigators showed was that mindfulness-based psychotherapy behaves as an anti-inflammatory. There's a test called the TSST, the Trier Social Stress Test. Simply put, you take volunteers, you get them to put a little speech together in a room in front of people, which for a lot of people is quite anxiety-provoking. You check their blood, you check their cortisol, their inflammation, and so on. People who, in fact, were participants in mindfulness-based therapy and engaged this paradigm exhibited significant reductions in immune and stress responses. The other area which I wanted to touch on briefly is the gut. You've been hearing a lot about this, the enterotype. That, in other words, what is the bacterial signature, or the not just the bacterial, but all the various viruses and various organisms in your gut? What does that overall signature look like? And I think by now many have heard that in depression, there's been a replicated observation that in the gut of people who have depression, who have bipolar disorder, there's a decrease in the natural diversity of these organisms. And as a consequence of that decrease in the natural diversity, That leads to things like leaky gut, which then leads to things like inflammation. This pathway, along with communication to the brain through the vagus afferent neural system, is thought to relate gut disturbances with brain disturbances. And it's been expanded now to include obesity, diabetes, heart disease, and depression. So in short, one other piece of this jigsaw puzzle linking medical comorbidity to mood disorders may, for some people, that jigsaw puzzle piece might also include changes in the enterotype, that is the gut signature with decreased diversity. So then begs the question, is there a role for probiotics or prebiotics or antibiotics? And I would say not yet, but those are hypotheses that are being evaluated by colleagues in different parts of the world right now, wherein can these manipulations, can these interventions that seek to manipulate the enterotype have beneficial effects on concurrent medical and psychiatric problems? By the way, just to finish that thought, colleagues are also looking at fecal transplantation, which you know is a treatment of choice for individuals with Clostridium difficile superinfection. They're looking at fecal microbiota transplantation, FMT, as a potential treatment for depression. Sounds like an interesting area, not the work I'm doing myself, but we'll keep a close eye on that. So the concept is really interesting, but we'll just see where that goes. Now, one other aspect that I wanted to bring up, and this is a really important point I want to emphasize for all my colleagues today, is I want everyone to finish the sentence in its full. So people with depression have an elevated risk of medical problems, but the sentence doesn't end, and they have an earlier age at onset. And that's a different conversation. So not only are they more likely to have heart disease, diabetes, and downstream dementia and so on, but it occurs at a much earlier age at life. And I recall many, many years ago, worked with a colleague in South Carolina, Jeanette Jarrell. Her and I discovered that in adolescents with bipolar disorder, they had a much higher risk of heart disease than the general population. Heart disease in young adolescents with mood disorders. And a colleague of mine in Toronto, Benjamin Goldstein, child psychiatrist, does a lot of really interesting research on bipolar disorder and cardiovascular and cerebral vascular risk factors. He's documented really concerning stuff in adolescents with mood disorders, showing when he looks at their arteries and their neck and their brain and so on. These kids have subclinical vasculopathy. In other words, what we're seeing in people who have depression what is akin to a premature aging process. So far I've been really talking a lot to the inflammatory process. It's not the only process. There's cortisol, there's also insulin dysregulation. But for those who may be a little less familiar, the telomeres in your cells are the little caps at the end of your DNA. Just imagine those caps on your shoelaces. And these caps, the shoelace caps on your DNA, they get shorter and shorter and shorter as your cells age. And what's interesting is that in depression, what we see is shorter telomeres relative to chronologic age on your birth certificate. So depression is a premature aging disease. And premature aging is facilitated by a whole host of factors. Again, inflammation, which we call inflammaging, metabolism, which we call metaboptosis. And so it's not only that people are more often affected, but it occurs much earlier in life. And I've been around long to say that I see a lot of folks in their 40s, sometimes 30s. I've actually seen patients in their 30s, but in their 40s with onsets of Alzheimer's disease, onsets of dementia, and chronic diseases like heart attacks and this type of thing, which we typically associate with people in their 60s and 70s, maybe a bit younger, depends on your status. But I see this in people in their 30s and 40s, and that's speaking to this sort of premature aging process. So I made reference to this earlier. This is a colleague of mine in Toronto, Ben Goldstein, does a lot of this work in children. But this is work in adults. And really what I wanted you to know is even the patient who's sitting in front of you, who says to you, I've got depression, and you've coded depression in the chart, the patient may have a normal BMI, a normal waist circumference, maybe, and the patient otherwise, seems healthy, but underneath the hood, so to speak, they often have a lot of problems. Now, this is actually an interesting analysis that was done. This study was looking at metabolic syndrome in adults with depression. And what they found when they looked at their arteries, looking at those carotid arteries, which is a risk for stroke, people who have depression tend to have, especially women, tend to have more stiffness of those arteries. So often we don't see this. I mean, obviously you wouldn't see their arteries. But the point is that when you see depressed patients, we need to think about depression as a multi-organ disease state. The patient is complaining of sadness and depression and anhedonia and cognitive problems. That's the brain part. But other organs are clearly affected. And it comes down again to this whole thing around inflammation and insulin resistance. This is the big part of it that's driving this overlap with these conditions. And it's not a fait accompli. A lot of this is certainly modifiable. In other words, there's lots that we can do here to slow this process down. And I say that because every line of research that looks at variables that are associated with medical comorbidity in depression and bipolar disorder, among other things, observes that medical comorbidity is more likely to be reported or observed in people who've had multiple episodes of depression or mania when compared to someone who's had one or two episodes. And I think every clinician knows that to be true. In other words, the more your illness progresses, as evidenced by more episodes, more chronic active illness, the more likely you're going to have medical problems. Now, part of that, again, is a iatrogenic effect. It's a side effect of the medication, because the more episodes you have, the more medications you're exposed to. That's one factor. But also, the more episodes you have, the more likely it is your body's going to be exposed to the chaos of the stress hormone release, the inflammation, the cortisol, the insulin resistance, among other factors. That's actually what's driving some of this stuff. And a number of years ago, I wrote a paper that obesity metastasizes to your brain. And this is something that I like to speak to, because obesity is one of the, and in many cases, the most common medical comorbidity in depression and bipolar disorder. And there's a separate body of research of looking at obesity and its effects on brain. And just to bring everybody up to speed, we know that people who have obesity are more likely to have changes in their brain structure as well as their brain function. We actually see brain volumetric loss in people with obesity, especially very severe obesity over 40, BMI over 40 kilogram per meter squared. And what's interesting is that we know that there are disorders in psychiatry that are characterized by impulsivity as well as disturbances in reward that increase the likelihood of obesity. And these include ADHD, depression, bipolar, schizophrenia, and binge eating disorder. So a brain that has been wired in a way that's abnormal, subserving impulsivity and disturbances in reward, can result in behaviors that put the person at risk of obesity. Conversely, if you have obesity, that could progressively and very deleteriously affect brain structures related to impulsivity and reward. And this analysis, which was published a few years ago, showed that brain aging is accelerated in people with obesity. It's also accelerated in people who have PhEP. PhEP is first episode psychosis. A lot of these people have bipolar disorder. And if you have both PhEP and overweight, the brain aging is even greater. That's the far right, that red circle with the confidence whiskers on the far right. So when we see a patient in our office who has depression and obesity, that person has a greater likelihood of accelerated aging of their brain. So this is a very interesting observation. It speaks again to some of these molecular players that I've been really emphasizing over and over again, and it also speaks to this intersection of depression, and more specifically, the intersection with reward. And this was an analysis that was done showing that when CRP is elevated, and it's more likely to be elevated in patients with trauma, loneliness, non-response to antidepressants, and obesity, the patient's more likely to come into our office and complain about apathy, amotivation, anhedonia. I've heard many colleagues quite pejoratively say, oh, the patient's lazy. Well, I don't know if patients are lazy. It's a kind of pejorative. I wouldn't say that. I would just say that patients clearly have a lesion. They have a lesion in their brain, and that lesion is in the area of the reward system that makes it so difficult for them to engage meaningfully in psychosocial and other treatment modalities to manage their depression and manage their illness. Just last week was the 100th anniversary of the very first patient in the world who received insulin for diabetes. It was at my hospital, actually, in 1921. The Banting and Best Institute at the University of Toronto is now a very famous place. And as they say, the rest is history. But why I've segued into this topic is because up to half of people who have depression or bipolar either have type 2 diabetes or have subclinical type 2 diabetes. And insulin in the brain is in the brain to serve as a neurotrophic peptide, as well as a neuromoderator. It modulates other neurochemistries. Moreover, insulin's also a monoamine oxidase inhibitor. But when your brain is in a state of insulin resistance, insulin cannot act as efficiently as a monoamine oxidase inhibitor, and consequently, that decreases dopamine signaling. I've always been curious why it is people with type 2 diabetes or subclinical diabetes, type 2 diabetes, especially if they have concurrent depression, why are these patients so apathetic? Why are they so anhedonic? Why are they so amotivated? And also, why do they complain so terribly about cognitive problems? Well, we don't have the whole answer. We got part of the answer here. And part of the answer is that insulin resistance decreases dopamine availability. Therein is why patients have got to get exercising. They've got to get weight loss. They've got to get normal sleep. They've got to get appropriate treatment for their concurrent diabetes if they have it. Because these disease states, like diabetes, are directly affecting the brain. In the October issue of the American Journal of Psychiatry, published just a few weeks ago, I wrote an editorial, and the editorial is entitled Metabolism Metastasizes to the Brain. And I speak to this interface, this medical interface, specifically insulin. And here's the part that I find really, really, really interesting, is that not only are we seeing, in fact, increased risk of morbidity and mortality from heart disease in people with persistent mental illness, but if in fact you have these metabolic problems and you have depression and bipolar or schizophrenia, this is looking at schizophrenia, you're more likely going to have cognitive problems. In other words, you and I struggle with getting our patients more functional. The reason why mental illness is so costly to the individual and society is because patients can't fulfill their role function, and consequently they require caretaking or disability provisions of one nature or another. And the principal reason why an adult with schizophrenia or an adult with depression or bipolar is not able to function is because they got cognitive problems. And one of the great contributors to cognitive problems in our patients is obesity, diabetes, heart disease, and metabolic syndrome. That's what the report is getting at. Now, when you do a blood test on a patient and you look at their sugars, A1C, for example, it is well established, you know this, that diabetes and is linked to not just vascular, but Alzheimer's disease, but so is depression. And when you have elevated A1Cs, not only does that indicate poor insulin glucose homeostasis, but it also gets you a little concerned about inflammation. And inflammation is also playing a role because sugar is pro-inflammatory. And I love this study from Israel. This study looked at adults who have diabetes. And what's interesting is that I get patients referred all the time to me with diabetes. And the question is, do they have depression? Now, for some, it's very clear they do. And the rate of depression is twofold higher in diabetes than the general population. But for many, it's not that clear because they don't really have the full DSM-5 criteria. They're apathetic, they're anhedonic, they're not motivated, they don't take their diabetes medications, they keep forgetting to go to appointments, and they got cognitive problems. And this study showed that if you have those A's, the apathy, the amotivation, the anhedonia, and diabetes, you're more likely going to develop a dementing disorder later in life. So that does suggest to me that not only in the near term does diabetes and depression have overlapping symptoms like cognitive problems, but it also gives me a little bit of a spooky kind of flag here that maybe that patient is at greater risk of dementia later. And that raises a very important question. If we can better treat depression and comorbid medical problems now, can that reduce the risk of experiencing dementia later? This is a report from my colleague, Rodrigo Mansur. He's in my lab. We looked at the relationship between obesity and depression and people's performance on monetary reward tasks. And what we discovered is what probably won't surprise you, and that is that people who have depression are impaired on a monetary reward task. But if they have obesity and depression, there's even greater impairment. And we think, again, this is because of the further disruption of cognitive systems and reward systems. Let's, in fact, if we can, in the last few minutes, just go through a few other things with you here. And to me, this is, in fact, why I am so interested in the convergence of medical and depression on the brain. This was a study that looked at this issue, but in a very clever way. They paid patients to take their antidepressants. And that might seem a bit peculiar to people, to pay people cash to take their medication. But by the way, that's been shown to really positively and adaptively influence health behaviors. And they found that when they paid the patients were more likely to take their antidepressants. They also found that they paid them more and more as the weeks went on. They did even better. That's called the escalating group. You can see the rates of adherence, 90.7 in the escalating group over 8 weeks or so, 6 weeks. The de-escalating group did not too bad, a little lower. They got paid less as they got closer to the end point. And the control group, so that's about you can see it's about a 20% improvement in compliance. But that's not really the gist of this. The gist of this is that when people are taking their treatment for depression, for diabetes, heart disease, obesity, most don't take it. More than 80% of people will not be taking their medications or their psychotherapy or their diet beyond 3 to 6 months. So this is why it's so critical to understand what's going on here. Now, there's not one explanation. There's many factors at play. But one of the factors is people who have depression and obesity and diabetes and heart disease have greater impairment of the reward system. They are much more likely to not engage in recommendations for treatment. This means that you and I have got to get that depression thoroughly treated to get those cognitive appraisal systems, get the reward back to normal, get these people, get their brain in a position where this silent appraisal process, is it worth it for me to do all this effort to get my life better? They answer in the affirmative. That's why this depression's got to be really, really, really treated. Now, in the last couple of minutes, I just want to let you know how this kind of comes together for us. Ketamine is a drug that we've been giving at my centers for depression. You all know it's approved for rapid-acting alleviation of depression and suicidality. There's a story unfolding that people with depression and obesity, or depression and trauma, or depression and elevated inflammation may be better responders to ketamine. I wouldn't say that's fully established. I would say that if I could use a baseball game as the metaphor, we're kind of in the second or third inning of that game. So that game's not over yet, but the second or third inning readout is saying this is interesting. The ketamine responders are even better in people who are inflamed or traumatized or have obesity. So again, this is how this intersection academically begins to enter into the conversation clinically, maybe informing treatments. And I think one of the better examples of this for me, I don't know if I have the slide here, is omega-3 fatty acids or even L-methylfolate. These are treatments that many of you have prescribed to patients with depression as augmentation. And I assume, like me, you've had maybe some hits, but you've had a lot of misses. It didn't work in a lot of people. And people have come back and they've interrogated this, and they've looked at the data, and it turns out that these types of treatments, omega-3s and exercise and L-methylfolate, they might work better in people who have depression and select medical comorbidities like obesity or diabetes and conditions linked to inflammation. I made this point earlier in my talk that some of these immunomodulatory drugs that are better known in the area of inflammatory bowel disease or psoriasis or arthritis, in addition to having important therapeutic effects on those designated conditions, these drugs also positively influence mood symptoms. And this is inspired development. People are looking at repurposing some of these, in quotes, medical drugs for possibly antidepressant treatment. And this is an example I'm just going to show you. We published this a couple of years ago. Infliximab is Remicade. And I did a study where I gave Remicade or placebo to adults with bipolar depression. And we discovered that it worked in people with a trauma history, which is in fact a discrete type of depression in people with mood disorders and more of an inflammatory type biophenotype. So again, I'm not suggesting infliximab as a treatment for our patients, but perhaps our future treatments for depression in the future may be informed by some of these historical events like trauma. Maybe one day we'll get to the point we're going to take some of these blood tests like CRPs and see where that goes. Let me show you other examples of repurposing. In mental health, I think metformin's used most as a weight loss strategy for psychotropic-induced weight gain. But metformin is also an antidepressant. It inhibits the inflammasome as well, which is an inflammatory molecular kind of population of proteins. And there's a lot of interest now in repurposing anti-diabetic drugs. For example, GLP-1, which is better known as liraglutide and semaglutide. GLP-1 is a drug that you've all seen. It's given for obesity and diabetes. Well, GLP-1 also exists in your brain. And we have shown through some of our work that GLP-1, which is produced in the hindbrain, a place called the nucleus tractus, projects to the cortex and also to the reward system. And there's another protein called the GIP protein. There's a new product from Lilly for diabetes that integrates GLP and GIP-1 together. And these are also being looked at in psychiatry. And here's another one of these drugs called dulaglutide. It's a diabetes drug. Well, it's been shown to improve or slow down cognitive deterioration in people who have diabetes. We've just started a study at my center where we're giving patients with depression either placebo or semaglutide, Onglyza, as a potential treatment for the depression. These are not diabetics. These are not people with obesity. So this is an example of how we take this concept, we take these clinical observations, we try to find points of overlap, and can that then inform what we hope to be de novo development of new treatments or repurposing of pre-existing treatments in people who have mental illness. And my lab has been looking at GLP-1 for quite some time because it plays such a key role in cognition and reward directly, and also indirectly by enhancing insulin sensitivity, as illustrated by this slide. Let's wrap it up with one or two more slides. This is really cool. This was a study that showed that if you give people antidepressants during COVID, they're less likely to have complications from COVID. That's interesting. And then this study appeared in JAMA about 10 months ago, and it was replicated in Lancet Global Health 3 weeks ago. Investigators found that fluvoxamine decreases decompensation from COVID. Again, to be clear, the SSRI is not being given to treat mental illness, it's being given to treat COVID. And this was, again, replicated in Lancet in a Brazilian study, almost 1,600 patients, where fluvoxamine was much better than placebo at decreasing the need for, ICU admission, ventilators, decreased oxygen sats. And the theory has been that some of these antidepressants, which are known to be anti-inflammatory through a protein called Sigma-1, are protecting patients. So here's another example of how understanding this molecular intersection of psychiatric pharmacology and or psychiatric illness and medical problems has led to some very interesting and innovative approaches. And by the way, why this is relevant is not just academic. In many parts of the world, you probably know the vaccination rate is very low, in fact, less than 5% in many of the poor countries. And they're not going to get vaccinations anytime soon at a rate that we'd like to see. And so to treat people who are getting COVID, we need strategies. There's not a whole lot of cost-effective strategies. Fluvoxamine is not on the World Health Organization's list of essential medicines, but fluoxetine is, Prozac. And Prozac, like fluvoxamine, is also a Sigma-1 agonist. Actually, there's about a dozen antidepressants that do that, not just this 40-oxetine, we got ketamine, we got dextromethorphan, a whole bunch of them. Anyway, but the point is that this has public health implications, because if we can protect people in poor countries who are infected with COVID, who don't have access to good health care, they don't have vaccines, and we can treat this for a penny a day, a couple pennies a day, that would obviously be a pretty cool finding. One final comment about this is around the issue of psychosocial treatments. I strongly believe CBT, mindfulness, exercise, all these, they're not just antidepressant. They've also been shown to be affecting the immune system positively. And we think that's actually what's going on here. And that's why we really, really think that they should be integrated along with diet. And this is a study we did showing that if you calorically restrict people who have they don't have a medical problem, we're just calorically restricting them. Caloric restriction, by the way, is the best way to slow down cellular aging, and it's anti-inflammatory. So this is all part of a larger holistic approach of dietary manipulation, improving cognition, reducing inflammation, along with psychotherapy and along with their medication. So with that, I'm going to stop there. I think, Ben, we're going to open up to some comments or questions anybody might have on the topic and in the remaining time that's been allotted.
Hey, thank you, Dr. McIntyre. That was wonderful, as always. And Cliff Tennyson is going to join us, and we have a few questions in the chat box. But I want to ask you a question, since you're in Toronto. What are your thoughts on the heated debate out of the Montreal Heart Study, the
the heart problems cause the depression, or the depression causes the heart problems?
Yeah, it's a great question, and I think the answer is it's both. And I think that when you look at patients who have depression longitudinally, they do have a higher risk and higher event rate of cardiovascular events and cerebral vascular events, and that's pretty well established. Conversely, when you look at people who have no prior psychiatric history, when they have a cardiac event like an MI, they have a significant increase in the risk of depression. And for quite some time, there was a rather simplistic formulation that they probably are depressed because they are suffering now from this terrible medical problem that just happened, and in many cases very life-threatening, and wouldn't you be depressed too, was the usual sort of commentary years ago. It turns out that it's more complicated than that. And it turns out that there's many aspects of depression or sort of cardiovascular that do overlap with depression. And so you begin to see, for example, alterations in the autonomic nervous system. In other words, the beat to beat variability of the heart is affected. In that scenario, you see more inflammation in that scenario. And a variety of other things like oxidative stress and also insulin resistance. So there's no question that there is a signal now documenting the risk is bidirectional. It's not just cross-sectional, but it's been shown to be a longitudinal risk. And that's why I think it's really interesting, the data that's come out of largely Australia, but other places as well, that if you've never had mental illness and you have a heart attack and you're treated with a statin, you have a much lower rate of depression than the person who had a cardiac event who didn't get a statin. So it goes to show you want to really optimize the treatment of both conditions. And that's not something anyone's going to debate. I think we all agree on that. But the tragic reality is that in the real world, once you have been designated as a psychiatric patient, the concurrent medical problems often get less than best practice care. And conversely, if you have a medical problem and you tell the clinician, I've also got a psychiatric problem, then you start seeing less attention to the psychiatric problem. So I think these are biases and so on that we have to address. But certainly managing both simultaneously, no one's going to debate that. No one's going to say, no, we shouldn't, but it doesn't happen. And it's critical that we do.
That's great. Cliff, I know there have been a number of questions in the box, so I'm going to turn this over to you so I don't dominate with asking all my mental health geeky, nerdy type of questions, okay? But I have one more, so you go ahead with a few.
Well, yes, there are some already here from our attendees. Let's go ahead with the first one. I'll just read it to you, Dr. McIntyre. Do you think that the premature aging observed with bipolar and mood disorders results from the disorder itself or from the symptoms such as a lack of sleep, cortisol issues, etc.? And I'll just throw in there that this is still, we still want to separate the two, don't we?
Yeah.
Even when we're trying to understand that they're not separate, we want to understand which comes from which.
Yeah, absolutely. I think, in fact, I guess the short answer would be that this is still a work in progress. So a strong statement one way or the other would be my opinion rather than the data. My second comment would be is that we agree that bipolar illness is a group of illnesses. And so the trajectory of illness is very different across people and very different within people. It can speed up and slow down, as we've all seen clinically. So I think the way I interpret the literature today is when this illness manifests itself clinically, which is usually in the late teens, early 20s, sometimes early 40s, but usually it's late teens, early 20s. At that point, the malleability, in other words, how how changeable the illness is at its greatest point. In other words, where you and I can make the most gain is in the early part of the illness trajectory. That's the same for just about every chronic disease. And what I would say is when we look at aspects of telomere shortening or other molecular or cellular or circuit-based changes that are taking place in the brain or body of a person with bipolar, you always see these problems more often in people who've had multiple episodes of illness, who've had more chronic, refractory, recalcitrant illness. So what that's telling me is that much of this is a consequence of episode, consequence of inflammation, cortisol storms, insulin resistance. In other words, the neurobiological sequelae of the episodes. And that's more hopeful because that means if we can get this diagnosis accurate and timely, get people on the right treatments, keep them well in the long term with whatever modalities of treatments work for them, then that should in fact delay and maybe even forestall and maybe even prevent some of these unwanted. In other words, I don't think it's a fait accompli. It's not a done deal that you have this life of awful, bad trajectory in premature aging. So I do think the preponderance of literature speaks to active illness as being the enemy of the state. Does the illness itself also have pre-wired, built into the genome, premature aging aspects? Possibly, but I don't know that. Well, what I do know is the latter. That is, it's the active illness that's dragging this thing through the mud. The other part about this as well, it's a reminder of how psychosocial elements can be relevant. The age at onset for bipolar disorder is much younger in people who've been traumatized. And that's relevant because you could turn that positive and say that does speak to an opportunity. If we can get people in a better psychosocial circumstance, that might actually, well, it won't change the age at onset because they already have the illness, but maybe we can provide a much more beneficial illness trajectory. So in short, I think it's an opportunity because most of the evidence indicates it's the chronic active illness that is taking this thing down the pathway of premature aging.
Let me ask this. Related to that, when we're trying to do a full assessment and be very thorough with our patients, when we see something that we think of with regard to chronicity, either the chronic nature of the mood disorder or the chronic nature of the medical physical disorder, so if we separate that, is it more important to look at persistence or recurrence or both? Or is that differentiation unnecessary? And we just need to think of chronicity as the evil.
That's a really interesting question. The way I would look at it is, I don't know the answer to that question, but what I would say is that for me, the concept of allostatic load is how I conceptually frame this. So again, for those who may not know that concept, or it's a little rusty, whenever organisms are faced with a changing environment, a stressor, the animal has to adapt and then assimilates to the new equilibrium. And if in fact you're under states of chronic stress, you adapt. And most people do adapt, but some don't. And when you don't adapt in the context of chronic stress, you begin to have what's called allostatic load. And allostatic load just means wear and tear because you're just not adapting. And my read of the allostatic load literature, the damage done to the body and brain in bipolar disorder, is a function of how active the illness is. So I would in fact conjecture that whether it's chronic illness or it's episodic illness, it's almost a mathematic. It's just active illness, and whatever one is the most active, that's what's going to see the most problems. I think that the reality, though, is that chronic illness, by its very nature, being chronic, there's no recovery. Those scenarios don't provide much opportunity for resiliency enhancement, much opportunity for adaptability. So taken together, my guess would be that it'd be more chronic. But if you have 10, 20 episodes, that sounds pretty bad too. But my suspicion would be the chronic would win out in that very morbid scenario.
There was a real specific question here right at the end where one of our attendees asked, in the final 2 slides discussing the use of antidepressants in the treatment of COVID-19, did the medication have to be started early in the disease process to be effective?
That's a good question. These patients, yes, was the answer. These patients were, again, they're not psychiatric patients. They were patients who had COVID. They were identified on at the hospital. You can imagine how fast these studies happened. These were people who tested positive for COVID, were symptomatic with COVID. They signed the consent form to be part of the study. So it was happening very quickly. And they were obviously sick enough to come to a hospital, and they were randomly assigned to placebo or the drug. And so the short answer is yes. Given how we know how fast this bug works, this happened fairly early, it seemed to me.
Here's an overall question. I guess I'm going to call it that. And maybe a fuller definition of our concept of what we mean by syndrome. Will we eventually learn that what we call psychiatric disorders are more appropriately designated as symptoms of multi-organ disorders? I don't know that will do away with psychiatry, even any more than in the practice of general medicine we do away with obstetrics and gynecology or any other subspecialty. But I think the question is more built around, will this increase a general acceptance of mental and behavioral impairments in the same way that we think of a broken leg?
Right. It's a great question. There is a literature on this very topic about acceptance and stigma of mental illness and the degree to which we biologicalize mental illness, and does that help stigma? Does that in some ways hurt stigma? But my own take on this is that putting the politics and the history and the culture and the healthcare system aside from all the factors that drive super specialization of medicine, and just speak just to the mother nature disease states, it's getting increasingly difficult to really, in fact, parse out and suss away mental illness as somehow so divorced from these other medical problems. And increasingly, the science has taken us is that, yes, they're brain disorders, but they're multi-organ disorders. I speak to dermatologists, I speak to rheumatologists, neurologists, all the other subspecialties, and I'm always reminded that we're looking at the same animal, but just different parts of the animal. It's just incredible. And now we've learned so much now about the neuroscience of these mental illnesses that really it's a conversation that overlaps with these other medical problems. So there's other forces, of course, that influence why specialties exist as their own specialty. But it's certainly on the science, it's getting really difficult to keep psychiatry so separate away from everything else. I'll just say it that way.
Well, Dr. McIntyre, I'm going to ask the final question before we let folks go to their lunch break, if that's okay. Yeah. So I'm going to preface it first by telling you some mental health nerd type of geeky information that's out there. The health insurance world considers, as do employers who are very much concerned about the health and well-being of their employees, they consider the big four conditions to be heart disease, diabetes, cancer, and obesity. Mm-hmm. And you know, the Milliman folks did this interesting study a while back and reported to employers that basically if you're providing regular standard treatment for the big four conditions, you know, heart disease, diabetes, cancer, and obesity, and you're not seeing any real improvement of those conditions, then Milliman has a recommendation, and that is to screen for and treat for depression and anxiety. And I wanted to hear your insights on that before we wrapped for this session.
That's interesting. I would love to see mental illnesses prioritized as well, along with those other four conditions. But I think that, look, I think it's a Venn diagram. And we're talking, everything you just mentioned is a Venn diagram. These are overlapping circles. And the big one that is probably one of the biggest circles of all is mental illness. And so I would say that's an interesting way that group sort of recommends things. I don't know the group, I don't work with the group, but I would say let's put depression as one of those concentric circles. It was interesting because I was speaking to a journalist at the Washington Post, and she was lovely. And she was covering our article where we found that people with depression and bipolar disorder are at greater risk of COVID and its complications. And she asked a question, which I thought was a really nice question. She was asking it quite, I think, with good intention. She said, well, if people with depression and bipolar already have obesity, already have diabetes and heart disease, and those conditions are already on the list, what does your paper add? I mean, why is it important to also have depression and bipolar on the CDC's list? Because aren't they going to get prioritized anyways through the back door with other conditions? And I said to her, good point. And I think you're probably right. But I think, first of all, we need to recognize that our illnesses are on parity of risk. And that's important in and of itself. And secondly is I think that there's something about the campaigning and advocating for our patients that's also relevant. And I think thirdly, I think we really want to make the case that people with depression have medical problems as much as other groups make the case that medical problems also have psychiatric problems. If you see where I'm going with that. So I don't know if I quite answered it, Ben, but that's kind of how I approach it.
Yeah, you did. That was wonderful. So for our friends in the audience, it's 11:59. We gift you back a whole minute. So you can take that and have your lunch break or return phone calls or whatever, and visit the exhibit hall. We will resume promptly at 1. And I think what we'll be doing is sending people back to the conference website because of the tech issues, and look for the Zoom link attached to your session that you're choosing, so that we can navigate through the tech problems that we had earlier. So thank you very much. We'll see you all back at 1 o'clock.
Yeah, thank you.
Thank you, Dr. McIntyre.
Thank you so much, everybody. Take care.